Peptic ulcer surgery is performed to treat complications of peptic ulcer disease, such as perforation, bleeding, or obstruction, when medical management fails. The sequence of peptic ulcer surgery involves several stages, including preoperative preparation, the surgical procedure itself, and postoperative care. Below is a detailed outline of the sequence. 1. Preoperative preparation. Proper preparation is essential to optimize the patient's condition and minimize risks. A. Assessment and diagnosis. History and physical examination. Document the patient's symptoms, history of ulcers, bleeding, or perforation. Diagnostic tests. Upper gastrointestinal GI endoscopy, abdominal x-rays, CT scans, or contrast studies to confirm diagnosis and identify complications. Laboratory tests. Assess hemoglobin levels, coagulation profile, liver and kidney function tests, and infection markers. B. Stabilization of the patient. Resuscitation. If the patient has a perforation or severe bleeding, resuscitation with IV fluids, blood transfusions, and electrolyte correction is done. Medications. Proton pump inhibitors, PPIs, antibiotics in case of H. pylori, and hemostatic agents if bleeding is present. Nasogastric tube for decompression in cases of gastric outlet obstruction or perforation. C. Consent and counseling. Explain the procedure, risks, benefits, and possible outcomes to the patient or their family. 2. Surgical procedure. The type of surgery depends on the nature and severity of the ulcer complication. A. Anesthesia. General anesthesia is administered. B. Access to the abdomen. The abdomen is accessed via a midline laparotomy or laparoscopic approach, depending on the situation and surgeon expertise. Specific procedures. 1. For perforated ulcer. Simple closure. The perforation is sutured with an omental patch, Graham's patch. Definitive surgery. If the ulcer is recurrent or large, a vagotomy with or without antrectomy may be performed. 2. For bleeding ulcer. Direct hemostasis. Bleeding is controlled with sutures or electrocautery. Definitive surgery. If necessary, vagotomy and pyloroplasty or antrectomy are done to reduce acid production. 3. For gastric outlet obstruction. Pyloroplasty or gastrojejunostomy to bypass or relieve the obstruction. Definitive surgery. Vagotomy may be combined with pyloroplasty to prevent recurrence. 4. Elective surgery for chronic ulcers. Vagotomy. Truncal vagotomy or highly selective vagotomy to reduce acid secretion. Antrectomy. Removal of the antral portion of the stomach to decrease gastrin production. 3. Postoperative care. Postoperative care focuses on recovery, complication prevention, and management. A. Immediate postoperative period. Monitoring. Vital signs, urine output, and signs of complications, e.g. infection, leakage, or bleeding. Pain management. Use of analgesics, nutrition, gradual reintroduction of oral feeding starting with clear liquids. B. Complication management. Early complications, wound infection or dehiscence, anastomotic leak or abscess, dumping syndrome or delayed gastric emptying. Late complications, recurrent ulcers, malabsorption or nutritional deficiencies. C. Follow-up. Regular follow-up to monitor healing, recurrence, and manage complications. If H. pylori infection is identified, eradication therapy is essential. Surgical variations. Some specific surgical techniques may vary. Truncal vagotomy with antrectomy reduces acid secretion and removes ulcer-prone tissue. Highly selective vagotomy preserves the pylorus and minimizes complications like dumping syndrome. Gastrojejunostomy creates a bypass for obstructed regions. In summary, the sequence of peptic ulcer surgery is methodical from thorough preoperative evaluation and stabilization to precise surgical intervention tailored to the ulcer complication and meticulous postoperative care.